Hello, everyone. It's 3:30 p.m. on Wednesday, April 29th, 2020. Thank you for joining us. This is Janet Hill of the Rock Island County Health Department. Today, we have with us Nita Ludwig, the Administrator of the Rock Island County Health Department, Ed Rivers, the Director of the Scott County Health Department, Dr. Ludwig, Katz, an Infectious Disease Expert and Medical Director of the Scott County Health Department. Our speakers do not have prepared statements, but they will be willing to answer your questions to the best of their abilities. We ask that you direct your question to the person you are addressing in the chat box, and the question and answer section will be moderated by Brooke Barnes of the Scott County Health Department. Nita, please start us off with your case update. Thank you.
Thank you. Today, the Rock Island County Health Department is reporting 24 new cases of COVID-19, bringing the total number of cases in Rock Island County to 426. Currently, there are 23 patients that are hospitalized. All of the 24 cases today are isolating at home.
In Scott County, 4 additional cases were reported for 222 cases total from 2,270 tests. That's 90.22% negative. We still stand at 5 deaths.
Thank you, Ed and Nita. Next, we will hear from Dr. Lewis Katz. So go ahead, Dr. Katz. Thank you for being with us today.
Well, Brooke asked me specifically to address all the interest related to antibody testing that's been in the media over the last 7 to 10 days. And I want to do that briefly, and hopefully I will do it in English. So you know that we do the diagnostic test with a technique called PCR, polymerase chain reaction. That detects the genetic material of the virus directly. They're very sensitive and very accurate tests. And by accurate, I mean, if they tell you you're positive, you're almost certainly positive. If they tell you you're negative, not quite as good, but pretty good. By contrast, the antibody tests that you're hearing about so much recently detect the immune response to the virus. So you get infected, and your immune system begins to respond and produces protein molecules called antibodies that grab onto the virus and hopefully eventuate in its killing and clearance from the system. Antibodies start to form around the end of the first week of illness, 7 to 10 days after infection, and the levels rise for a number of weeks after that, so that by 4 or 5 weeks, 5 or 6 weeks, antibody levels are reliably actually quite high, depending on the test you use. I compare the two kinds of tests in a kind of a simple way. The nucleic acid tests, the PCR tests, are science. The antibody tests are art. They're very, very difficult. Those tests are difficult to develop and often have taken in the past as long as years to develop to the point that they're extremely accurate. There are somewhere in the range of 300 antibody tests being developed and marketed out there, and almost none of them are well enough characterized that we know what they mean. And I think this is a critical issue. Their performance, that is, the ability to find people making a real immune response to the virus and to miss people who have not been exposed or infected with the virus, are uncharacterized. There are a number of tests out there that I'm familiar with, and some of them look like they're going to be good tests once we have enough data to prove it. Others are totally uncharacterized, and there are many of these assays that are frankly not good, certainly not good enough to use for any sort of diagnosis or decision making. Even the best of these tests that are available for clinical use cannot be used to establish that somebody is immune to the virus. And the reason for that is that we don't know what constitutes immunity to the virus. We don't know what kind of immune response is important so that somebody is no longer susceptible to the virus, and we don't know how long any of the immune responses last. So we can't use these tests to tell people they're safe and they can go back to work in a hospital setting or in a congregate setting or in a public setting where they're likely to be re-exposed to the virus. Very, very important that you understand that none of these tests have enough data behind them to be able to say to a person with a positive test that they are immune to the COVID virus. An additional problem is that many of these tests, and we're not sure which ones yet, pick up antibodies against related coronaviruses that circulate in the community constantly and cause nothing more than the common cold. So that's called cross-reactivity. And when you have antibodies to those and you're tested with one of these developmental tests, they'll tell you you have a positive test, and it's what we call a false positive. So none of these are useful for telling people they're immune. None of these are useful for, quote, reopening, end quote, the economy, the community, etc. This is critically important that you understand that these tests are not ready for those kinds of applications. There are a number of reasonably good tests, I think, and their value in the short run is going to be in public health. We know enough about their performance that if we do a bunch of individuals now and again in a couple of weeks and again in a couple of weeks and again in a couple of weeks, we can see the trend in the positive rate in a population and have a sense for where we're moving toward herd immunity. But we cannot use these for decision making on individual patients, and we cannot use them for what you're really interested in, which is to prove that you're immune to the virus or to prove that it's safe to be reopening the community in the broadest sense. Will the test get better? Absolutely. Will it take years? No, I don't think so. The effort being put into making these tests work is very, very substantial. So I think in weeks and months, I'll be able to change what I'm saying. But I wanted to have the opportunity to tell you in the clearest possible language, these tests are not ready for prime time. Outside, I think, of some very, very limited venues, the most important one being public health surveillance, as we begin to talk about how to approach what we call herd immunity. Herd immunity being enough people immune in the population that the virus no longer spreads as effectively as it does now. I had one more point I wanted to make, but I'm approaching my 70th birthday and I can't remember what it was. I swear to God.
Well, we can give you.
Well, if there's some questions,
Yeah.
it may come to me.
We can give you, thank you, Dr. Katz. We can definitely give you some opportunities to add in additional information. And we appreciate you coming on and describing the differences between the value for the public health community to use this information versus, as you described, individuals in the community to have an understanding of that.
Remember now.
Okay, you remember. Please go ahead and add your last point.
Yeah, you guys may be aware, guys and girls or whoever's on the phone, you may be aware that a number of the very large national commercial labs are beginning to advertise the use of antibody tests without a physician's order. And I want to discourage that in the strongest possible terms for all the reasons that I just indicated. These tests do not yet provide useful information to an individual patient. And if I had my way, these large labs would not be allowed to offer the tests yet. That was it.
Thank you. First, we've had a couple of questions that came to us ahead of time, as well as some in the chat. There's 2 questions in the chat that relate directly to what you were saying, so I will go to those first. What does uncharacterized mean? And if they aren't useful, what's the purpose of those tests, which I think you did address in the second portion of your talking point.
Yeah, when you develop this kind of test, the standard approach, which has been really short-circuited by the FDA allowing these tests to be used without good characterization, what you do is you have a large panel, hundreds of samples from people that you are absolutely certain did not have what you're looking for, people who you are absolutely certain had or have what you are looking for, a group of samples from patients with a wide variety of diseases that are other than what you're looking for. And then you look at how the test finds the people that have it, misses the people that don't have it, and whether there are interfering factors from people with a wide variety of other infections, autoimmune diseases, cancer, and a whole wide variety of things. Until you characterize the test on those large panels of samples to prove you find what you're looking for and miss what you're trying to miss, we don't know how they work. Now, I can give you an example of what happens when we haven't done that. You would think that if I had a test that found 95 out of 100 COVID-infected people, that's pretty good, okay? And you would think if I had a test that missed 95 out of 100 people who didn't have it, that's pretty good. Those two parameters are called sensitivity and specificity. And 95 and 95 is pretty good under some circumstances. But when you are in a position that we're in now, where somewhere between 1 and 4 or 5 or 6% of the population has been infected yet, the performance is much different than what 95 and 95 sound like. If I have a population with a 5% incidence, that is 5 people in the population who are infected, I test 100 people, and there's 5 who have been infected, and it has a 95% specificity. That is, it has 5 false positives per 100. Half of every test that you get back that's positive is wrong, okay? The false positives will be equal to the number of true positives in that population, and it's no better than a coin flip if I'm trying to tell a physician or a nurse or a first responder that they've been infected and now they're immune. It's no better than flipping a coin having done that test. That's what characterizing these antibody assays requires and represents. And I can expand on that if it's needed. But the bottom line is where we think we are in the epidemic at this point, and with the performance characteristics that are being described for some of these tests, it's no better than a coin flip when you get a positive result.
I did see another question on there about how Dr. Katz's lead in. I did want to say that we are recording these briefings, and they will be available on the Scott County Health Department site. So we'll defer you to be able to look at, review the recording, which usually gets posted about 15 or 20 minutes after we conclude here. So that will give you some of that introduction information. Looking here through the questions, make sure I'm getting some that are relevant to what he was just discussing. I think we'll just go to some of the questions that came originally, which is to the broader response that's happening here. Dr. Katz, have we avoided overwhelming the healthcare system, and how is that measured?
Well, yeah, I think the health system hasn't crashed by any stretch of the imagination. But as I talk to the bedside clinicians and nurses on a daily basis, they're plenty stressed out. The longer it goes on, the more difficult it gets. My understanding is there's enough beds and enough ventilators to take care of the patients. That's a good thing. The physical infrastructure is holding up well enough to get by. My biggest concern in the short and medium term is the human capital involved in delivering care and how long they can maintain the high level of performance they've been trying to maintain before fatigue and depression and anxiety begins to set in. I have colleagues in New York City, and I know that they passed that point some time ago. Hopefully, we're not going to get there.
We do have another question that perhaps you can respond to generally. Have we flattened the curve, and what's the basis for decision-making at this point?
As I look at the curves that Ed Rivers is generating every day with reported cases in Scott County, we still haven't reached the peak. I think we may be approaching the peak, but we are a long ways still from being on a downward slope for 14 to 21 days. That would be the absolute minimum that I would accept for starting to back off on the measures that are being taken.
The next two questions are interrelated, and it's about the spread of COVID-19. What have we learned about asymptomatic and pre-symptomatic cases of COVID, and just generally how the virus is spreading? When
we began dealing with this in January and February, and the first cases were being recognized a variety of places around the world, we used SARS-1, which you'll remember from the early 2000s, and the Middle East respiratory syndrome coronavirus as examples for the best guess on how this virus spreads. They were both spread almost entirely by what's called droplet and contact. So that was the original model for SARS coronavirus 2. We have discovered that there is some proportion that may be airborne, which is more like TB and measles than straight droplets. So there's a proportion we don't understand that's being spread airborne. And we know that probably from 1 to 3 days before the onset of symptoms, there's enough virus in the upper respiratory tract that people are capable of transmitting the virus. That's before symptoms. There is a substantial reservoir of asymptomatic infection. Some of it's really asymptomatic. People never get sick. They tend to have less virus than others, but not enough that I can tell you they can't transmit. They tend, if you follow them for a few days, actually not to be asymptomatic, but to have been pre-symptomatic. I think that asymptomatic, pre-symptomatic transmission to an important degree is supporting continued spread of the virus. And I also believe that that is probably very much under-recognized in pediatric populations who are fully susceptible to the virus, but they just don't often get sick. So I suspect at the end of all this, we'll find that rugrats are a source of transmission that we didn't appreciate early on.
One last question related to some of what you discussed earlier. Is herd immunity the goal? I'm assuming that's related to the antibody testing. And what do we expect to be the time frame when we have an understanding of that?
Well, when you've seen one pandemic, you've seen one pandemic. So I don't know the answer to that question. We don't have a good enough handle on the degree of penetration of the population yet. And I don't think we will until we're confident that we have antibody tests that can be used widely in epidemiologic studies, and we can get representative population samples from the population that will tell us how much spread there's been. There's been a lot of studies publicized in the media recently, none of which are peer-reviewed, and all of which were badly flawed in how the populations to be tested were selected, and clearly ran the risk of extensive bias toward the high side of the number of people who have antibody to the virus at this point. The studies that you've probably heard the most about are in New York City and Santa Clara, California. And frankly, I don't think those studies are to be trusted. The populations from which the samples were drawn were not representative of the population, and we're just not there yet. So talk to me in a month, in 2 months, in 3 months, and I'll have an answer for you. We'll have better tests, better characterized, and we'll have appropriately sampled populations to give us data that we can rely on.
Another question related to Iowa and the loosening restrictions. As we know, Iowa's loosened restrictions on 77 counties based on the metrics that the governor and the Iowa Department of Public Health have developed. Do you agree with this move or with the decision to let churches and farmers markets be open in all 99 counties?
I would not have made those recommendations.
Thank you, and you've given us some other information earlier. We have two related questions. I know we discussed this right before the call. We're seeing the disparities between the number of cases in Rock Island County and Scott County. Do you have an idea, the explanation that we've been looking into, if it's related to some of the poverty impacts in Rock Island County? Do you have any information or anything to add in terms of an explanation for the disparity in the number of cases?
I'd probably be able to answer that if I knew what proportion of the people at the Tyson plant lived in Rock Island versus Scott County. I think that's probably a piece of it. And then whatever's left over would require a lot of investigation to understand. I would ask my co-workers, Ed and Nita, to comment.
Nita, would you like to address that first, please?
Sure, I can go ahead and comment on that. So it had been longstanding Department of Public Health policy in Illinois not to publicly identify facilities that have outbreaks. However, this is an unprecedented situation, as we all know, and Illinois has now identified outbreaks in the long-term care facilities or nursing homes on their website under long-term care outbreaks. So with that in mind, I can go ahead and confirm that Tyson in Joslin, Illinois does have an outbreak going on. And we do know that a lot of refugees and immigrants and people of color in general that live in the Illinois Quad Cities do work out at the Tyson plant. So that could be certainly at least one of the reasons for the higher numbers on the Illinois side. But I can also say that we have been working very closely with the leadership at the plant, and they have done many mitigation efforts to try to stop the spread of the infections out there. They've been very open to listening to public health and our environmental health staff, and they have taken our suggestions, and I do think that they are trying whatever they can do to try to minimize the spread of the illness. We do know that meatpacking plants all across the country seem to have a lot of infections going on, and that is because of the nature of their work. But we also know that, of course, the president has now basically mandated them all to stay open. So our best efforts are to try to reinforce all the mitigation efforts that they're doing, continue educating all the workers and staff on hand washing, and covering coughs and sneezes and everything that we can do to keep people safe. I do know that they have instituted wearing masks at all times and face shields at the plant in Joslin as well.
Nita, we have a couple of questions as a follow-up to that. Are you able to confirm the number of cases that have been reported to the health department from that location?
Yeah, I don't have the current numbers in front of me. I would be happy to report that, but I don't want to give inaccurate information. So if it would be okay, I would get the current numbers and have them ready for tomorrow.
Thank you for that, Nita. It looks like one additional question here for Dr. Katz. The goal of flattening the curve was to prevent overwhelming the healthcare system. What can we expect now? Should we be thinking, oh, everyone will eventually be exposed?
Well, I hope not, because everybody eventually exposed means a lot more morbidity particularly in the high-risk groups. But I think it's also important to recognize that in New York City, 40% of the hospitalized people were under the age of 50 and had no or few comorbidities. So assuming that everybody's going to have to get exposed to the virus before this goes away would mean lots more morbidity and mortality. So what we're trying to do is slow things as much as we can until effective preventive and treatment interventions become available. There's some encouraging data on an antiviral drug from the NIH, not yet published, that is becoming available. And of course, I think the ultimate hope is a preventive vaccine. That's many months away.
Nita, an additional follow-up question. Is there evidence of the cluster at the Tyson plant in Joslin being spread among workers, or could it be general community spread?
Sure, so I think the answer is yes to both. Like I said, the nature of their work is that it's very hard to do social distancing on the production line. They have done some mitigation efforts like slowing the line and putting some barriers between the workers, but it's just a difficult industry to try to do that with. But I do think some of it is community spread as well. And I was just chatting here about the numbers, and what I can tell you is there, as of this morning, there was about 92 cases that I can tell you about. And again, I can have the more accurate numbers tomorrow. And there have been 2 deaths of Rock Island County residents.
Thank you. Please type in any additional questions. If not, we'll work on concluding the press briefing for today. We'll give it about 15 more seconds.
Don't drink bleach.
We do have one additional question. I'm trying to find that in here. I apologize, WQAD. I did have it up on screen. Janet, do you have the additional question that was sent to us on the employers and providing information to those workers in the community?
1 second. I am away from my office at this point. I'm in Nita, so she's going to look up. I did email it to her.
I apologize for that. We did have those, and then we received a couple additional in there.
Yeah. No, it was the other one. It was okay.
Dr. Katz.
That's the wrong thing.
Dr. Katz, in the meantime, I have a question there on your use of a mask at this point. Are you limiting your external places that you're going to?
I'm not going out. I carry a mask with me if I'm within 6 feet of people. I spend most of my time in an office with a closed door at the blood center, but if I'm going to put myself in a situation where I'm going to be closer than 6 or 7 feet to other people, I have a mask to use.
Okay.
And I wouldn't have gone to mail without a mask.
Yes, go ahead, Nita. Thank you for finding that for us.
Okay, so there was a question about, are employers required to notify their entire staff when there's a confirmed case in the workplace or just close contacts? And the answer is yes, employers are required to tell staff that someone has tested positive for COVID-19, but they are not required to name that employee. With COVID-19 being spread widely through our community, employees who are at work should be working at least 6 feet apart if possible, and should be cleaning their workspaces frequently with the touch surfaces often, and of course washing hands often, and covering coughs and sneezes, all those things that we have been talking about. The close contact is defined by CDC as closer than 6 feet for 10 minutes or longer, and those people should be informed if there is a coworker who has been in that range of space for that period of time to them. And as far as workplace safety, we also got some questions about that. And of course, employers are legally obligated to provide a safe workspace. There was a question about communication of cleaning and disinfecting, and that could be that it is occurring in this particular person's workspace, but maybe that just hasn't been communicated effectively by the management team. So we, of course, would encourage everyone to share all the mitigation strategies that they're doing to keep their workers safe.
And Ed, for Scott County, would you like to respond to the question about information that's provided by employers to staff when there's a confirmed case in the workplace?
Well, when we receive a report of a positive case, we contact that individual and discuss it with him and request that they inform their employer. And after a period of 30 minutes, we will call the employer and talk with them about the positive case and provide guidance to them. The Iowa Department of Public Health and the Occupational Health and Safety Administration both have guidance documents that they can follow.
And our last question, Nita, we'll go back to you for, this is related to the Tyson plant and how you're doing the follow-up. Have all family members from the plant at least been notified about the outbreak, and who else?
Yeah, so any person that's a worker there that is a positive case would have one of our nurses, if they live in Rock Island County, they would have one of our nurses contacting them and talking with them about family members and whether or not they need to isolate or whether or not they have any symptoms and would need to go get testing as well.
Thank you for joining us today. Thank you again to Dr. Katz for all of your insightful information. His last wording is wash your hands and cover your cough.
Stay 6 feet apart.
And stay 6 feet apart. So the great public health information we've been sharing the entire time. So again, we thank you all for participating today, and we look forward to talking with you again later this week. Have a good day.